Hello and welcome to CureMD's webinar, The Plugs That Pay. This is a webinar regarding identifying leaks in your revenue cycle management that can put more money into your bottom line. My name is Robert Goff. Thank you for joining me. The information that I am about to present is general information. It does not substitute for legal advice, so if you do have a legal issue, please see a competent healthcare attorney. All right, let's talk about some of these things that really cut into your revenue. And we have to realize the payers are not going to be coming up with more money. Your reimbursement rates are not going up from any commercial payer or from Medicare. So if there's no higher rates coming, how are you going to improve your bottom line? You're going to have to look for money within your own practice and within the practices that you use within your practice. This is a whole listing of items that you can put attention to that have payoff, at times sizable payoff. From copays and deductibles, how to use verification, making sure services are billed, underbilling, money lost on margins, timely filing denials, opportunities that are lost in billings and resubmissions, insurance underpayments, and retractions. So let's get into a little bit. Copays and deductibles. You know, it used to be that copays were $3, $5, $10, a small amount, small financial transaction between the patient and the office. This has changed dramatically. Copays are up, running about $30 on a copay. You know, you think about that, $30 on a copay for a physician practice with 3,000 encounters a year, that's $90,000. Miss just 10% of those copays a week, that's $9,000 being lost. And if you start billing for them, you're chasing patients and it's costing you money. Deductibles, whoa, those used to be virtually non-existent. Well, now we've reached the point where the average is $1,800, and many times the patient is going to end up paying the full fee for their office visit. With 33 to 40% of non-elderly adults having outstanding medical bills, your challenge has to be to make sure you're not the one that's holding the debt. Tighten up your process. Look to collect copayments and deductibles at time of service. And this starts with verifying the eligibility and coverage for patients. That means what their deductible status is, what their copay should be. But you need to understand that what you're finding out from the payer is not guaranteed. Right? And if it's not guaranteed, what are you going to do? You're the one left holding the bag. Well, I've been recommending for years that offices seek to require a credit card as a backup guarantee, a contingent guarantee, if you will. That is, at the time of the visit, and tell the patient before the visit, you require a credit card on file as a backup to the information the insurance provides. Tell them right off the top that your insurance company doesn't guarantee the accuracy of the information, and therefore you need to have a process in place when the payer is not accurate. Now, you don't use the credit card unless first the patient says, please use it for the appointment, or when the insurer comes back and says, oh, that $20 copay you collected, well, it's really $30. Well, you don't want to bill and chase for 10. Bill the credit card. Oh, that deductible, we told you that it was fully met. Well, they really have an outstanding balance. Again, bill the credit card. You don't want to be in the position of chasing patients for these balances. All right. First, your costs go up, and secondly, you're left in the debt. Now, let's recognize the reality that for some people, whatever it is that they owe, even if you do have a credit card guarantee, is going to be difficult for them to pay. So you want to invite your patients at the time they register to self-identify if they have an economic issue with making payment. And at that point in time, make your payment arrangement. All right, I'm not going to be able to pay for the office visit. You know, my deductible doesn't cover it. It's going to run about $250. Eek, I can't do that, in a month. Well, how about we turn around and get a credit card authorization to bill it over 2 months? Work out the problem up front. Additionally, the physician then can help the patient with arranging other care by being sensitive to their economic concerns. You need to balance assuring you get the money as well as making sure your patients are comfortable obtaining services. Again, the credit card has worked wonderfully in most practices as a backup contingent. So provide the services, whatever is paid and collected at time of service, great. Bill comes in, there's a difference. Bill the credit card. You're not chasing. You're not sending out notices. Good system. Now, you got to make sure that you're actually billing for everything that is done. Believe it or not, 5 to 7% of services provided aren't making it onto the bills. This is especially true if you don't have an integrated EHR and practice management system. If there is any kind of process where the information in the medical record is not fully and completely transferred to a super bill, which is what happens automatically in an integrated system, then you're going to have things drop between. If your system does not have the ability to sweep the medical record over to the bill, it isn't integrated. Time for an upgrade of the system. If you're not using both billing and EHR, and I know practices, unfortunately, that have the capability that's still doing billing the old way, you're leaving money on the table. You're losing it in the process. Now, what slips if you have a good, tight system, integrated EHR, is when the physician goes to the hospital. You're going to have to create a little system. You know what all the patients that are in the hospital, make sure the physician has some way of recording that, yes, they saw that patient. I've used 3x5 cards where the physician has it and checks off. It's a little printout that maybe you get from the hospital where you can identify not only that it's your patient, but where they are, so the physician knows where to go. We'll have them take that list with them, keep a copy. They can add to it at the bottom if they saw somebody unexpectedly or did a procedure in the office, and then make sure you collect it on a daily basis. I'm sorry there's not a better automated system for that, but you got to close that gap as well. Now, when you are billing, don't make the mistake of leaving money on the table. If you're getting paid 100% of what you billed, then you're maybe leaving money on the table. What happens? Well, there are offices that try to bill out the allowable schedule because they don't like write-offs. The problem is if the fee schedule changes, maybe goes up because of an adjustment, and you get paid 100%, maybe you could have gotten paid more. So bill out your usual and customary. The plan will always pay the lower of the amount billed or the allowable. So if you go, I'm billing 100 and the fee schedule has been adjusted a couple of dollars, you're leaving those couple of dollars on the table. And when you bill, make sure you not only add the number of units, because if they don't see any units, many of these billing systems, payment systems, will pay 0 because, there's a description, but there are no units, so you must not provide anything. Likewise, if you don't fill in a dollar amount, they're going to pay you the lower of what you bill or the allowable. You leave it blank, they'll think 0 and pay you 0. Now, you got to get the bills out the door. That should be self-evident. But believe it or not, the AMA says 17% of all claims are being denied for timely filing. So, number one responsibility, get your bills out the door. Don't batch. Don't do it weekly. Don't do it twice a month. Don't do it monthly. Do it daily. You should be electronically sending out your bills every single day. It improves your cash flow and it'll allow you to identify problems sooner. Billing has to become a daily basis. That means send out and every day look on the payer's website for those bills that are 30 days old that you haven't been paid for. Because if you got a bill outstanding at 30 days and you don't see it on the payer website, rebill it immediately. That means they didn't get it. Don't argue about whether or not it's been sent. Sending means nothing. You can prove you sent it. But your obligation is to make sure it's received. So, bill daily. Identify anything that is older than 30 days on a daily basis. Shouldn't be very many if you're billing out daily. If it's not listed on the payer website as being received by them, bill it out. If it's listed, great, they got it. If they got it, they're going to either pay it, Deny it, reject it, they're going to do something. But it's not lost, and it's not lost to timely filing. So you have to make sure that it's received by the plan. Now, believe it or not, 10 to 30% of claims are rejected. But what is unbelievable is half of rejected claims are never resubmitted. Offices that batch things up, then get a batch of things to be corrected, they don't get around to correcting because of other things intervening. This is another reason why billing has to become a daily activity. Because if you get a rejection, you're not going to have that many on a daily basis. Collect them, correct them, and resubmit them. Fix it fast. Get it back in. All right? You don't want to lose any claim due to a rejection. And understand the difference between a rejection and a denial. If it's a rejected, you have to fix it. If it's a denial, you have to appeal it. So 6 to 14% of claims are denied, but half of those are never appealed. Yet 70% of all appeals are successful. So if you don't appeal, you lost the money. You have to look at a denial as another opportunity to get paid. And even if you don't get paid, at least learn something to avoid a future denial. Read the EOB, understand why, and look to appeal. All it takes is a letter, and you can set this up on computer. This practice is appealing the denial of the attached claim. You denied this claim, claiming that the practice failed to, whatever the reason is, get authorization. You are incorrect. Attached as proof. Please make payment at this time. Simple as that. What was the reason for the denial? What proof that you have that they are wrong? Now, if they're denying it because the patient doesn't have coverage or that doesn't have the benefit, you don't have any information to prove that they're wrong. You can't speak for the patient. You don't know whether or not they paid their premium. You don't know what their benefit package is. Don't bother. This is where to appeal it. This is where you go back to that credit card on file and you bill the credit card, tell the patient. It becomes the patient's problem to argue with the insurance company. Now, you've billed out, you've appealed, now you've gotten paid. How do you know you're getting paid what you should? And are you getting paid what you should? And are you letting yourself be underpaid? Well, practices get underpaid because of the chilling effect of coding and documentation audits. 5 to 10% of practice revenue is lost for that reason. Well, practices use 20 to 30 codes. If that's the case, get good at the documentation required for those 20 to 30 codes. You don't have to get good at the documentation of the entire CPT book. You don't. But you have to get good at the codes that you frequently use. And get the documentation down. Now, if you have an EHR with Code Checker, you can confirm the sufficiency of your documentation to support the coding level, but make sure the services are appropriate for the diagnosis. So, if it doesn't warrant the service, if the diagnosis doesn't warrant a level 4, you don't need the documentation. It doesn't matter what the documentation is to support the level 4 because the diagnosis doesn't apply. But don't get into the false habit of trying to avoid challenges by downcoding yourself. Don't take your 4s to 3s to avoid being identified. Better to get the $50, $60 differential in rates and have your knowledge of coding and documentation down that any challenge, if it happens, will withstand the challenge. It's not a bad idea every couple of years to bring in a certified procedural coder and have them see how good you are. You may learn. Time and time again, I've seen practices that have been undercoding, bring in a certified procedural coder, and being able to add $20, $30, $40, $50, $60, $70,000 more to their practice a year by proper coding and documentation. Regardless of what you have computer systems trying to help you, it's a good thing to do. Now, the other area of loss and not getting paid what you should is that, believe it or not, payers underpay you. How could that be? Well, on the average, practices are underpaid 6%. That's on the average. practices in certain specialties, certain sections of fee schedules don't get paid what they should. Some payers are better than others. The issue is you're the one, if you don't identify it, if you don't see a problem, and you don't do something about it, you lost the money. Now, if you have a practice management system with Right-Remit, you have features that will automatically be able to compare what you were paid by what you should have and identify and even give you appeal letters ready to be sent out. If you don't have it, then you need to create self-audits. So build yourself a self-audit tool. And this is something every practice should be doing for every payer. Don't get overwhelmed yet. All you need to do, if you don't have a Right-Remit, is build your own little worksheet. Take your super bill, put in the fees that you should be getting. Now, you don't want to do all of them. Do the top 20 codes. Remember, practices don't do 1,000 codes. So do the top 20. Right? And if you don't have access to the fee schedule, then you have two choices. One is to build your own. Do it on an Excel spreadsheet by over time taking the CPT code and the dollar amount paid on a paid bill and entering it in and seeing, hey, the code should be X. Won't take you long to build that schedule. Also, it's not a bad idea to take your top 10 and send it to the payers asking for them to give you the fees. They're not going to give you the full fee schedule, but they generally will give you on request the top 10. So what you want to do is you want to take your little audit tool, and you're not going to do every payer every single day, but every week take one payer and look at their bills as they come in. And if there's something that's wrong, appeal it. Appeal says, dear plan, you paid me X. I believe that you're incorrect and underpaid me. Please make payment now. The worst that happens is they say, hey, here's what the fee should be. Not a bad thing to have happen. All right? So if you're in doubt, appeal. Make them do the work. Make them prove it to you. Now, there's another area that takes a little bit of aggression here, but you should not be avoiding. And that is dealing with the 2% of practice revenue that's lost to post-payment challenges. Payers take data dumps of paid claims, give them to commission-based vendors who go through them and identify suspected overpayments. That's suspected. It doesn't mean that they are overpayments. They may not even be legally entitled to recover the money from you. But as Lorraine Furbush at Oxford Health Plan said, just because regulations say we can't offset money doesn't mean we can't ask for it back. Physicians are expected to know their contract and the regulations. What is she saying? She's saying, we're going to ask for money back. And if you don't do anything about it, we're going to take it back if we can. If we can't and you're stupid enough to send us money, we win. Who cares? Well, you need to push back. You can't ignore these, because if you ignore it, what you're doing is giving them permission to take the money back. But all you need to do is another letter on your computer. This practice is in receipt of your letter requesting repayment of X. Be advised, we are in accordance with our rights under the Federal Fair Debt and Collection Practices Act and applicable state regulations disputing, and you need to use the word dispute, disputing your allegation. Please provide us with the following information to document your allegation. And what do you ask for? Well, I like to start off with a copy of a canceled check. How do I know that I actually received that money? If they say they overpaid you, I want a certified copy of the fee schedule that was in effect at the time of payment. Right? How do I know that, in fact, they're paying me according to the fee schedule at the time of service? Now, there are a couple of things that happen. What you've done is you've asserted rights under law. And these outside companies are looking to very quickly shake you down for the money. And what you're doing is you're saying you have rights under law, give me the documentation. Well, a couple of things will happen. One, you may get the documentation and see in fact you were overpaid, in which case send the money back. Many times, especially for smaller dollar recoveries, you'll hear nothing back. They're going to let the issue drop because it costs them so much time and effort to put together the documentation. And if they send you back a letter which says, we've looked at it and you owe us the money, you go back and say, excuse me, this remains in dispute. You have failed in your obligation to document fully and completely your rights to this recovery. Should you pursue this further, we will seek regulatory response to your improper demand. All right? Intimidation is a game that they play. Do not volunteer to be a victim. Now, not everything that they ask for back they're entitled to. So there are some things that sometimes they look for. Retroactive terminations. All right? They can't go back more than 120 days from date of service. All right? And if they got prior authorization, they can't go back at all. This is in New York. Other states can vary. Authorizations can't be withdrawn unless the patient was not covered. The look back is limited to 2 years unless there's a suspicion of fraud. And offsets or negative remits require at least 30 days notice. That's why you have to act fast when one of these letters come in. You got to dispute it, but you got to read your mail and you got to act. You can't say, oh, that's too complicated, I'll put it aside. And non-par physicians have to submit claims within 15 months of date of service or they're denied. So in any case, my recommendation is if someone's looking for money back from me, I'm going to dispute it till they prove otherwise. Simple as that. Now let me give you a little bonus item. Escheatment. Escheatment is the process of unclaimed funds. So what happens? If a payer sends you money and you don't cash the check for whatever reason, maybe the mail was returned to the payer because it didn't go in the window right. Maybe it got lost somewhere along the way. This money ends up after, depending on the state, but generally about 2 years, it ends up being considered abandoned property, and the payer doesn't get to keep the money. They return it they give it to the state. So once a year, you should look up or send a request for unclaimed funds from your state office that collects them. In New York State, it's the Office of the Controller. And just go to their website, put in the information, and you may find some unclaimed funds of yours. This should be done annually. It doesn't cost you anything really to do. But you know something? You may find some money that somehow got lost through your system. Better to find it. Better to get that money. So do that once a year. Now you can go back and you can ask yourself the question of, how did this money get by your practice? Who wrote it off? You know, if you're on top of your claims, you shouldn't have something that disappears unpaid. And what happened within your practice? That's the learning process. But more importantly, go to the payer, go to the states, ask for unclaimed funds. If you can find money, it's yours. No reason not to. Put it on your calendar for once a year. So let me thank you for attending the webinar. I hope you found it interesting. CureMD offers some tremendous technology to help you really identify and close these gaps, plug these leaks. And please, if you want to learn more about CureMD, contact us. This is Robert Goff for CureMD, and thank you so much for your time.